Now we move on. I would like to call Dr. Sanjeev Kumar Shrestha for the next presentation. He's going to talk on a very interesting topic, the cholesterol heart hypothesis and statin. Are we on the right path? Please, Dr. Sanjay.
Thank you for the introduction. My topic is cholesterol heart hypothesis. Are we on the right path? First of all, I'd like to thank the Cardiology Society for giving me this opportunity. First, I'm going to present my hypothesis, and then why the present hypothesis is not acceptable, and how cholesterol hypothesis originated, and why cholesterol is so important. And I'm going to also present alternative hypothesis for atherosclerosis, and I'm going to tell you how statin works, and I'm going to tell you about experiments that proves that statin in fact increases cell membrane cholesterol. It does not decrease cholesterol. I'm aware that the topic could be quite provocative. It could arouse anger when we are questioned about our beliefs, which have been strongly rooted in our mind and soul for so many years. But please bear with me for some time. My hypothesis is cholesterol is not the cause of coronary heart disease. Actually, deficiency of cholesterol in the cell membrane results in coronary heart disease. Why the present hypothesis is not acceptable? Cholesterol hypothesis, bluntly stated or simply stated, an elevated blood level of cholesterol is a direct cause of atherosclerosis. Therefore, taking any action to reduce cholesterol levels should be an important step in lowering the risk of developing atherosclerotic cardiovascular disease. However, the reality seems to be different. Despite a significant rise in statin consumption and obsession to lower the cholesterol levels, the coronary heart disease is on the rise. In 2010, 11.6% of Americans were taking statin, and following 2013 guidelines, an additional 10.2 million Americans without coronary vascular disease became candidates for statin therapy. And in 2014, it was recorded that 13.5%, that means 43 million out of 318 million Americans were taking statins. And statin consumption has increased all over the world. And in fact, it has become the biggest pharmaceutical business. It's a $30 billion business every year. But look at this WHO data picture. The leading cause of death globally, you can see that ischemic heart disease, which was less than 7 million in 2000, has risen to more than 9 million in 2019. And this another graph shows the global prevalence of ischemic heart disease is on the rise. And you can see that Western Europe, global, South Asia, everywhere, the coronary heart disease is rising. Now I'll tell you why cholesterol hypothesis is questionable. Because why do some people with high LDL cholesterol levels never develop significant atherosclerosis? Why do some people with normal LDL cholesterol level, widespread cholesterol filled atherosclerotic plaques? Why does lowering LDL cholesterol levels with statins improve cardiovascular outcomes, while lowering LDL levels with other drugs do not? For example, niacin, ezetimibe, bile acid sequestrants, fibrate, CETP inhibitors, and so on, they generally have not been able to show improved cardiovascular outcomes. Indeed, in some of these trials, of substantially worse cardiovascular outcome was seen with treatment, despite improved cholesterol levels. These results strongly suggest that the benefit of cholesterol lowering seen with statin therapy are specific to the statins themselves and cannot be entirely explained by simply lowering LDL cholesterol. For this reason, the cholesterol hypothesis, at least in its classic form, is now in serious doubt. Now, let me tell you how this cholesterol hypothesis originated. The cholesterol hypothesis was based on three important observations. First was Ansel Keys' 7-country studies. Second was pathologists showed a long time ago that cholesterol deposits are a major component of atherosclerotic plaque. And third, epidemiological studies, in particular, the Framingham Heart Study. Ansel Keys was a nutritional scientist from University of Minnesota and studied diet and prevalence of cardiovascular disease in different parts of the world and published a study known as 7-country studies. Though the study design is considered to be flawed by today's standards, his major finding linked high dietary fat to heart disease,
And the study became so influential that it was published in Time magazine in 1961, and USA changed its nutritional guidelines forever. However, he left out 15 countries out of 22 and cherry-picked only 7 countries that supported his hypothesis. So this was the greatest flaw in this famous study. And then came the Framingham study in 1948, which followed people aged between 30 and 62 living in the town of Framingham for 26 years. It aimed to determine common patterns related to the development of cardiovascular disease and identified a number of factors related to heart health, and that was smoking, hypertension, diabetes, and high blood cholesterol. But look at this famous Framingham curve. Look at it carefully, and you will see that this is the typical normal distribution of any biological parameters like height and weight. And you can see that there's a big overlap in cholesterol levels in those with and without coronary heart disease. And actually, only significant level is above 300. Now, just remember this 300. This is a key number, cholesterol level above 300. You can see that in the green area that most of the people did develop coronary heart disease. And I'm going to tell you why. Then came statin trials in 1990s. There came multiple randomized controlled trials, and that demonstrated lowering cholesterol improved cardiovascular outcomes. There's a question mark. For many experts, these trials proved the cholesterol hypothesis once and for all. These trials led ACC, AHA, and NCEP to formulate guidelines, and these trials were called landmark trials in cardiology. However, they were full of statistical flaw and exaggeration. Look at this famous advertisement by Pfizer. It says Lipitor reduces risk of heart attack by 36%. And it was based on Ascot-La findings, a large randomized controlled trial conducted in 2003. But look at the findings. It's 1.9% taking Lipitor suffered a heart attack, while 3% of placebo group. And that amounts to absolute risk reduction, ARR, of having heart attack decrease only by a tiny 1.1%. Whereas if you calculate statistically the relative risk reduction, it amounts to be 36%. So this is how the findings can be exaggerated by relative risk reduction. That's all statistical calculation. Statin trials investigator present relative risk reduction, typically 20 to 40% in these trials, rather than meager real world absolute risk reduction, which is only actually 1 to 2%. And then came Jupiter trial, another so-called landmark trial. And this has also been found to have statistical flaws and exaggeration, which I'm not talking about its details, which is available in expert review of clinical pharmacology. Then came so many other trials like Asteroid, Corona, GCHF, Aurora, and all failed to provide evidence that rosuvastatin therapy reduces coronary heart disease and its complications. Believe me, it is all in these journals. So statistical deception have created the appearance that statins are miracle drugs, when the reality is that their trivial benefit, 1 to 2% absolute risk reduction, is more than offset by their adverse effects. There are plenty of adverse effects. Now, let me tell you why cholesterol is so vital. Do we really need to decrease the blood level of cholesterol? Before telling that, let me tell you what is cell membrane. Cholesterol is a vital principal component of plasma membrane. Plasma membrane is a bilayer of phospholipids, all of us know right from our medical life. And this cholesterol interspersed, the yellow parts that you can see in the phospholipid bilayer, maintains integrity of the cell membrane. And it is also said that if it were not for cholesterol, we would be butter in low temperature and oil at high temperatures. And then kept the concept of lipid rafts in 1990s. These are microdomains highly rich in cholesterol and sphingolipids, and they form the scaffolds for various receptors and proteins used for signal transduction. And we know these signal transductions, communications between cells, are extremely important for maintaining homeostasis. And it has also been found that they have a very big role in proper immunology. And cholesterol is also obligatory precursor of steroid hormones, sex hormones, bile acids, and vitamin D. Shortly, talking about cholesterol metabolism, what happens? Its level in the cell is tightly regulated. Cholesterol is produced inside every nucleated cell because it is so important for their survival. And it is also taken up from outside, primarily from LDL. LDL attaches to LDL receptors on cell membrane and is internalized through receptor-mediated endocytosis. And LDL is broken down inside the cell. Most cholesterol molecules are added to the plasma membrane. It goes back to the plasma membrane, some to membrane of organelles inside the cell. For example, there are plenty of organelles, and for example, endoplasmic reticulum, and some are esterified and stored. Now, let me tell you the alternative hypothesis of atherosclerosis. Vascular endothelium, which all of us know is a monolayer of endothelium, when exposed to hemodynamic stress generated by the blood flow, it experiences a force known as wall shear stress, WSS, wall shear stress. And it is the force per unit area exerted on the vessel wall by the blood flow expressed in dynes per centimeter square. And physiological values of venous system is 1 to 6, and in the arteries 10 to 15 dynes per centimeter square. And we also know that the segments in the coronary arteries that are more prone to develop atherosclerotic lesions and plaque ruptures are bifurcations and curves. And these are the segments which the local hemodynamic factors such as wall shear stress plays a major role in the generation, progression, and destabilization of atherosclerotic plaques. A study published in Circulation in 2011 regarding coronary artery wall shear stress demonstrated that regions with high wall shear stress developed atherosclerotic plaques, increased calcification and necrotic core, thinning of fibrofatty cap, and vulnerability to rupture. In a study of endothelial cells from baboon aortoiliac grafts, high wall shear stress regions were associated with increased expression of substances known to promote vascular inflammation and vascular calcification. Therefore, inflammatory reaction is what initiates the atherosclerotic process. Cholesterol is therefore healing process. Cholesterol, in fact, maintains the integrity of the cell membrane, integrity of the bilayer of phospholipid. Experiments have shown that depletion of cholesterol from cell membrane using methyl beta cyclodextrin, MBCD, increases fragility and rupture of the cells. In fact, you can find this in biophysical journal. Now, some of you might ask me, then looking at this Framingham curve once again, why in very high levels of cholesterol, more than 300, look at the green area, that almost everybody develops atherosclerotic heart disease. And familial hypercholesterolemia, broadly two types, homozygotes develop atherosclerosis early in childhood, and their total cholesterol is above 600. Heterozygotes in early 30s, and their total cholesterol is above 300. Now, we can correlate this with the Framingham criteria. Because it's above 300, all of these are developing coronary heart disease. But the pathophysiology out here is quite different. It is actually the absence or deficiency of LDL receptors in familial hypercholesterolemia. And so, because of the absence of LDL receptors, there's inability to maintain sufficient amount of cholesterol in the membrane. That increases fragility and inflammation and atherosclerosis. So that is the pathophysiology. Now, let me briefly tell you how statin works. Every nucleated cell, I told you, has a mechanism to produce their own cholesterol from mevalonate pathway. Statin inhibits a key enzyme, HMG-CoA reductase, and prolonged intake of statin. This is the thing. Prolonged intake of statins result in very low level of intracellular cholesterol. And because cholesterol metabolism is so important for the cell, it has a negative feedback system which becomes activated, and it is mediated by a group of proteins known as sterol regulatory element binding proteins, or SREBP. So decrease in endoplasmic reticulum cholesterol results into translocation of SREBP from the ER to the Golgi and then to the nucleus for transcriptional activation of the target genes involved in cholesterol uptake, that is LDL receptors, and biosynthesis, resulting into upregulation of LDL receptors in the cell membrane. So upregulation of LDL receptors in the cell membrane results in more cholesterol being incorporated into the cell through LDL cholesterol. This is how statin decreases cholesterol in blood plasma. And LDL cholesterol internalized through LDL receptor is then redistributed in the cell, most being incorporated in cell membrane. Therefore, actually statin increases cholesterol in the cell membrane. This is proved by the following experiment, which was in Biochemica et Biophysica Acta. See, effects of different cholesterol biosynthesis inhibitors on the cholesterol content of plasma membrane fractions. See, what you need to note here is that cell cultures were left untreated, that was control value, or treated for 24 hours with 30 microgram per milliliter of free cholesterol and or cholesterol biosynthesis inhibitors. So what you can see is that the first line in that graph, that's control. Second line is the cell cultures grown in cholesterol, in the presence of cholesterol. So the raft cholesterol increases to 699. When the cell cultures are cultured in the presence of cholesterol biosynthesis inhibitor, which is known as SKF, the raft cholesterol goes down and non-raft cholesterol goes down to, you can see that 302 or 27, much less than that of the control value. But when it is cultured in the presence of lipoprotein rich medium, then actually the cholesterol content of the membrane increases. You can see that 508 has gone up to 529. And there's another cholesterol biosynthesis inhibitor, AY9944. It decreases to 333. But when it is cultured in the presence of cholesterol, lipoprotein, then it goes up to 671, which is much higher than that of the control. So this is exactly what happens in our body in vivo, because statin decreases the cholesterol. So because of the upregulation of the LDL receptors, it acquires more LDL from the plasma. And so the plasma membrane cholesterol, in fact, increases. Conclusion. So cholesterol is extremely important for cell membrane integrity. All nucleated cells obtain adequate cholesterol by de novo synthesis or exogenous cholesterol through LDL receptors. Atherosclerosis is initiated by inflammatory process, which occurs because of injury to the cell membrane, either due to inadequate cholesterol in the membrane or due to wall shear stress. Cholesterol, in fact, accumulates in plaques for the healing process. The small benefit of statin is because it increases cholesterol in the cell membrane. Thank you for your hearing.
Thank you very much, Sanjay. Such a nice presentation, and it really takes a hard effort to the concept of holy statin you are going to change. I think any question regarding this, one or two question is ready to answer. Anything? Any question from the floor? No. Okay, Rajesh is going to.
So now what should you do? Should we prescribe statin or not?
This is what I was expecting.
One thing I got today is one of my patient after doing angioplasty asked me, doctor, I don't drink, I don't smoke, I don't have diabetes, I don't have hypertension. You said my cholesterol is normal, then why did I have a heart attack now? Can you explain me? So I think from next time I'll show the slides. The thing which you have presented today, we need to rethink again, and this is maybe very closer to reality.
Yes. Thank you very much, Sanjay, for your excellent presentation.